This is a Geek Leader podcast, and I'm your host, John Rauda. This show is all about helping us grow as leaders, become better technologists, and improve our lives both at work and at home. I hope you enjoy the show and learn a lot. Welcome to a Geek Leader podcast. I'm your host, John Rauda. And if you could, please do me a favor and take a moment and leave a rating and review in whatever podcast player you're listening to this on, whether it's Apple Podcasts, Spotify, iHeartRadio, doesn't matter. I would greatly appreciate it. And that feedback really helps get other listeners to the show. Also, if you're not subscribed, go ahead and subscribe so you don't miss an episode. And if you feel so inclined, you can go to geekleader.com/tip and donate to the show. Thanks so much. All right, Geek Leaders, today I'm honored to have Kyle Kiser on the show. He is the CEO of Arrive Health, and they help healthcare companies and technology kind of boost up. We're going to talk more about what they do and how they do it. And anyway, with all that being said, Kyle, welcome to the show.
Glad to be here, John. Thanks.
So if you don't mind, just tell the audience a little bit about your background and how you got to where you are today in your career, and what is it that you do as CEO of Arrive Health?
Sure. So my background's been, most recently in early stage digital health type companies. But I started in the employee benefits business. So I came sort of from a payer perspective. So worked for wholesalers selling employee benefits through brokers to employers right out of college. And, ended up kind of curious. I mean, honestly, when you look in healthcare from the outside looking in, it's probably obvious, but, didn't want to spend my whole life just, handing out renewal increases, and got really curious about what it is that's driving cost up, what it is that is required to do something about that. And that curiosity directed me to corporate wellness at the time. So health promotion programs, health risk assessments, things within employers that sort of help the population of their employees live healthier lives. So that led me to Principal, the large financial services company based in Des Moines, had a wellness business and a health plan at the time. And so sort of transitioned to that. And that was like a 50-ish person startup inside of a tens of thousands of person financial services company. And I think that experience of being around those folks that were just so passionate and so focused and so curious, that it gave me that startup bug. And from there, was an early employee at a couple of digital health startups, and then came in as a part of the original team at what was once our RX Review and is now rebranded as Arrive Health. And so I'm in year 9 with this company and been on this journey for a while. And so what Arrive Health does is we tell doctors how much drugs cost as they're selecting them in hopes to guide them to lower cost options for their patient. So, this is to a non-healthcare audience mind-boggling at times, but medications are one of those places where it's the only place in the economy where somebody else is making a purchasing decision on your behalf, and neither of you know what it costs until you're asked to pay for it. So that's specifically the problem we're trying to solve, is how do we help doctors understand, or prescribers generally understand, the cost of the decisions that they're making before they happen. So where there are lower cost opportunities that are clinically equivalent, or a lower cost pharmacy, or just one option that's preferred based on your health plan, we can get that information in the hands of the prescriber before it happens. When we do that, first, patients get on medications they can afford, so they're more adherent, they manage their condition, they are healthier as a result. But to the doctor's office, they spend a ton of time fielding calls to rework prescriptions that just didn't go out the door within the scope of the payer preference. Or, if you're that health plan, more often than not, they have a preference of which medication they'd like that prescriber to choose within a certain class. And that, before us, that the visibility to that information was limited for that prescriber. So the goal is, everybody wins in this thing. Is patients get the medication they can afford and they can access. Providers have a less abrasive, less friction path to getting that decision out the door. And at the end of the day, the health plan associated with that patient saves money.
Yeah. It's crazy, being that I've been kind of a consumer of some of this stuff for a while. And as you're talking about it, I'm like, yeah, that makes total sense. Why haven't we been doing this all along? And, I feel the pain from, a parent of, I have a child that's got ADHD, and just that whole process has just been so frustrating. And I can think back to the first time he was prescribed something, and we went to go get it filled, and they're like, yeah, your insurance doesn't cover this. It's going to be like $275 a month or something like that. There's this, generic version of the exact same medicine that you can take that's only like $4 a month. Oh, well, why didn't we know about that?
Totally. Yeah, that's exactly the right example. So, when even simple things, if you're a parent, you've probably at one point had to go get an inhaled steroid for your kid the way that I do. You have to get croup or something. Albuterol is the one that's more often prescribed. And albuterol comes in a bunch of different forms. It might be a disc, it might be an inhaler, it might be a nebulizer. There's all these different types of inhaled albuterol. And usually one of those is $0 or $4. And all the rest of $200.
Yeah.
and so our goal is to just make those opportunities, or similar to the one that you just described, more visible as that decision is being made. And honestly, you're right, it is the way it should have been from the start. But it's complicated industry, and one of those that is, its time has come.
Absolutely. And also, I know this isn't the problem that you're probably trying to solve, at least not yet. But I know, when it comes to certain medications being what schedule they are, if it's a certain schedule of medication, then you can only get it as your prescription is starting to expire. And for us, that has been so complicated and frustrating, because I'll look at my son's medication, is like, okay, he's got 3 pills left, let me call and get this renewed. I'll call the pharmacist and I'll say, oh, well, he's out of refills, you have to call the doctor. So then I'll call the doctor will submit it to the pharmacy and say, okay, it's been submitted. Then I'll call the pharmacy and say, okay, is it ready to be picked up? And they'll say, oh, well, we're actually on back order and it won't be here for 2 weeks. Okay, well, can you transfer it to another store? No, we can't transfer that schedule, so you have to call your doctor and get them to send it. I said, well, do you know which store has them in stock? Oh, we can't tell you that. It's against the rules. I'm like, oh my God, this is so frustrating.
Yeah, no, it's a challenge for sure, especially in those more sensitive prescriptions as you're describing. It's a hard problem to solve, and the goal is to make that more visible, because ultimately, even outside of the complexity created by the systems and the health plan and the way we pay, the doctor's the right advocate, right? Like one of our co-founders, guy Kevin O'Brien, he's a doctor in Denver. He's really the sort of spark that started this company, because he was trying to help his mom. His mom, was a Medicare member, retired on a fixed income, said, hey, I've got a $600-800 monthly spend for prescriptions and I need help. So Kevin, looked at her meds, saw, this brand could be broken into 2 generics. This one could be pill split. This one had a therapeutic alternative, whatever it was, and cut her prescription cost in half. And what that inspired Kevin to start doing was he just started doing this at his clinic. So he, would see people coming into his clinic and want to sort of help them in the same way that he helped his mom. And so he started to build this massive spreadsheet of ways to save on your medication based on health plan, based on these sort of different methods of saving, some of those I just described. And that's really where we started, is because we needed to empower that patient-provider relationship, right? And it, we actually have a mantra in the company called Lucy Up. And it's because Kevin's mom is named Lucy. And so it's kind of our way to say, hey, step up, think about the mission when we're all in the details, when we're sort of focused on the next deal or the next project or getting the next feature out, that it's a way for everybody to sort of raise their eyes to the fact that this is about something bigger than us. And everybody's got a Lucy in their life, or they've been the Lucy in this context. So it's an important part of why we all show up and do the work.
Yeah. So, other than cost savings, what other kind of data can be put into, these models to maybe improve outcomes? Is there like any type of like information that's being gathered as far as efficacy or availability or things like that? Because I know, during COVID, when that was happening, there was a lot of medicine that wasn't available regionally, that were, supply chain issues and things like that.
Yeah, our lane is primarily around cost or affordability and access. Mm-hmm. So beyond pricing, we deal with with something called prior authorizations. So a PA is something that the health plan asks certain questions about expensive medications to ensure that the folks that are getting on those medications have either sometimes tried the lower cost option before that, tried and failed it, or they are of a certain severity that requires them to move to this sort of next level of expense.
Yeah.
So it might be, 3 to 12 questions about that patient to ensure that they're then eligible for this new level of medication. And right now that process is shockingly manual. It really is. So what we've done is now the cost insight is the start in our process of that prior authorization insight. And the goal is to start to automate those processes throughout the ordering workflows of doctors. Today, believe this or not, a lot of that work happens through fax. And so there has been some advancement of sort of turning the fax process into a portal-based process. But, a lot of that data is sitting inside the electronic health records. And so we're taking that sort of patient context from the electronic health record and starting to automate that throughout the process so we can get to an approval faster. So we're taking what's usually taken 3 or 4 days to get approvals and bringing it down to a few hours.
So are you guys integrating, or do you work with other companies and partners like, the only example that I have from a user standpoint is, I think you're aware we had to cancel the last interview because I tore my ACL again. But I use my surgeon uses my chart, which is, a way to get in there and put your information in and have, to kind of stop doing some of the repetitive things. Like, before you went to the doctor, they had you fill out the exact same form with your name and all your information on it and your medical history every single time you went. Now I can put it in my chart, and when I go to the doctor, I just prove that, everything's already pre-checked, and I just have to say, nothing's changed, and move on. Are you guys working with groups like that to try to integrate some of that information and have it all in one place?
Yes. So my chart is an Epic product. Epic is an electronic health record company that we work with. And so think of us as the data network that powers a feature inside of Epic, is what we do. That's the real estate we occupy, is when the doctor is ordering that medication, we evaluate that decision as it's happening, send it out to our network of information, which is primarily from health plans and pharmacy benefit managers to understand insurance costs. And then we intervene through the Epic system. So it's not our UI, it's their UI. We just populate their UI with our data. And so yes, the long answer to yes, we are definitely integrating with that type of software to create a more consolidated view and create more consistency and opportunities for call to action.
Yeah, that's really cool. And I think automation is one of those easy terms to use to try to find improvements, especially in healthcare, because we see it quite frequently that there's a lot of repetitive tasks that have to go on. Especially like I'm in my 40s, but my health isn't changing that rapidly yet. It probably will, but every time I go, for my physical, it's almost like the exact same thing. So I imagine that having a method to automate that information so that you're not having to, repeat every form and every piece of information, on a daily or yearly basis is one of those things that's almost like low hanging fruit when it comes to, improving healthcare.
Yeah, that's true. There's a ton of manual processes. I mean, even around just administrative tasks that every other industry is tackled in a pretty automated way. Just payment and these authorizations that we're working on. These are things that a lot of other industries have gone digital on many, many years ago. And that opportunity is just starting to present itself in healthcare.
Yeah. And do you think some of this is because it's sensitive information, or is it just we don't want to mess things up, so we want to take it a very cautionary approach? I know I've had someone on one time that was they were a manufacturer of healthcare devices, and they were talking about how like the operating systems that they have to write code for embedded software is 10 to 15 years older than what we're doing for mobile devices and things like that, because it has to be approved and vetted, and you have to go through all these, FDA regulations and things like that just to make sure that the device is proper, and not malfunctioning, and, going through the stringent test. Do you think is that same thing when it comes to data?
It's certainly a high stakes data set for sure. And there's a lot of restrictions around what you can and can't do with data that's regulated under HIPAA.
Yeah.
So there is a good amount of caution around all of that, but that's honestly just the pace of play in healthcare, to be honest, is that, new business relationships take a long time because everybody's very cautious around some of the things we just mentioned. And then that becomes an accumulating problem, is that, if you're building a multi-sided network in healthcare, which is the business we built, like, you can almost think of our business as like a ad exchange, right? Like, in an ad exchange business, you've got supply side inventory of advertisers that then put content into the a social media platform or Gmail or whatever that's got utilization. The users don't pay for anything. They just are populating the supply. The paid side is the supply side. The free side is the demand side.
Yeah.
Same idea, where it's not advertising, but it is, we have connectivity around pricing and insurance and benefit data. We have free utilization on the EMR side, and we're connecting those dots. Well, if you try to attack that problem in healthcare, then the challenge you run up against is you need enough users to get any of the supply side inventory to the table, and the supply side inventory doesn't want to come to the table until you have enough users. So there's this chicken or the egg issue. Mm-hmm. And so, you got to aggregate one side of that, gain enough scale to get the other at the table, and then you sort of have to ping pong one off the other until you gain that relevance and significant enough scale that it matters. So I think the challenge is that exists in every corner of healthcare, right? Like, if you just think about the prescribing process, there's probably 15 different nodes on that journey that each one of those nodes is a multi-sided network that has to be formed. And then you think about medical benefits, or you think about revenue cycle management, which is just healthcare speak for how they get paid. All of those things have different multi-sided networks associated with it. And so, because the data is so isolated in all of these different places in the industry, that it's just hard and slow. It's hard yards. It's tough plumbing to build.
So and this is probably me being stupid and asking a really dumb question, but are the different medications, do they have a competitive sense behind them as far as pricing is concerned? When I look at my, what was prescribed for my son for ADHD medicine, I have no idea. Like, is there a competitive pricing model going on in the background? Because all I know is this is what the doctor prescribed, so that's what we're getting.
Yeah, no, it is. The competition happens in a couple of different places. So on the insurance side, there's competition between, the therapeutically equivalent meds for formulary placement. And so a formulary is just a list of the preferred meds based on your health insurance. Mm-hmm. And there's tiers, tier 1, 2, 3, 4, how many ever there are, depending on your plan. And tier 1 meds are the least out-of-pocket cost for patients. And then, tier 3 or 4 are the highest out-of-pocket cost for patients. So medications are competing for placement in that framework. And then within those tiers, there are even preferred ones. So, in that category, right, they might be, Ritalin or Vyvanse or whatever it is, that there are certain ones, and the health plan may have approved the use of one of those and have preferred pricing and negotiated with the maker of that drug a specific price. And then as a part of that negotiation, they may exclude other things in that class that are therapeutically equivalent, because then they got the best deal for their members by negotiating a really good price on this one rather than negotiating with all 4 in the category. And therein lies the problem, because the doctor doesn't have visibility to that level of granular decision.
Right. So the doctor doesn't even know who my insurance is at the time of writing the prescription. They would have to go outside of their office, look at their computer, and say, "Oh, who's your insurance provider?" And then, "What plan do you have?" And try to figure all that out. Is that what you're saying?
That's right. And that's exactly what our system does. So in real time, in a sub-second transaction, we send it out to your insurance. We get the price back for your plan at your preferred pharmacy right now today.
Mm-hmm.
We share that with the doctor. And prices in pharmacies change from day to day. So you may have walked into that pharmacy on Tuesday and it'd be $35, and you walk in next Friday and it's $38. So that specific price can shift from day to day. And that's a different dark art that a lot of people don't fully understand.
Yeah, I guess part of that's probably supply and demand, and all that good stuff.
Yeah, that's true. Right. Every one of those pharmacies has a competitive pharmacy across the street from it, doesn't it?
Yeah. Yeah, that makes perfect sense. And it's so. I think about, like, I wish it was just completely transparent and open to where there was like a price tag on everything and you can kind of see it all at once. Is there a future place where we get to that point, or is it just going to be where it's just transparent for us and this is the best price and the best solution for what's going on right now?
Yeah, there's a lot of government discussion on that specific topic right now. So there have been more price transparency laws or regulations generally passed in the last 2 years than in the last 50. So there are now there are rules around health plan price transparency. There are rules around health system and provider price transparency. There's something called the No Surprise Billing Act, where used to you could get this massive bill if you accidentally went to an out of network provider. That's now been regulated in a really specific way, and it sort of ties together the two health system and health plan regulations. And then, most importantly, to us anyway, is CMS, Centers for Medicare and Medicaid, now has made it a requirement that if you're a Medicare Part D plan, which means a Medicare plan that provides prescription coverage, you have to have a tool that is capable of connecting to our systems like ours. It's called real-time benefit tools. So there's a lot of reasons for optimism. I think that there's a lot of activity in the space trying to make things better, and the regulators are at the table really trying to make things better. And so there's reasons to be optimistic that things will be more transparent over time, and a lot of discussion around that. I think the challenge is there's just this structural complexity because there's, if you're a commercially insured member, then maybe it's the plan sponsor who's your employer is actually the one paying the bill, and the health plan is in the middle administering that, and the pharmacy benefit manager is working on behalf of the health plan administering that. And that's just on the payment side, right? Not on the demand side, where a provider is delivering care and has a certain fee schedule to deliver care. And then the pharmacy has their own fee schedule to fulfill those meds. So it's just a complicated space. So it becomes a little bit of a game of whack-a-mole, because every time you gain transparency in one area, it becomes potentially more opaque in another, and the dollars move in that direction. So it's a hard problem to solve given the system we have in front of us, but there's a lot of people trying to do good in the area right now.
Yeah, so it sounds like we're making progress. What does the future of these healthcare transactions look like for us?
To me, I think over time, my personal opinion, not necessarily anything that the government's trying to do at the moment. I think things will move from what's called a defined benefit structure to a defined contribution structure. Right now, if you get insurance from your employer, you probably have a plan that they've selected for you, meaning the deductibles of a certain level, formularies predefined, the benefits are predefined, and they decide for you. And with that, you just carry forward in whatever way you can. I would expect that over the next decade or so, we will transition to something that looks a little bit more like a 401k. So think about the transition from pensions to 401k, where pensions have this defined benefit that they contributed to your retirement, and over time it grew. Whereas 401ks you have a budget and they match it, and you're sort of you have more agency in the decisions around that. My bet is that we go to more of a defined contribution structure in healthcare, where you have from your employer how many ever thousands of dollars a year to contribute to your healthcare premiums, and then you're able to then go shop for those that healthcare plan that makes most sense for your family.
Yeah, that makes sense because and that is one of the frustrating things because like you get in, I guess, seasons of life where you'll have a lot more expenses than other seasons of life, and like if you're going to have a baby, you're going to have more expenses that year as with a newborn and a young child than you would when you're single and in your 20s without children.
That's right. Yeah, I would imagine. I mean, it sounds like we're similar age, similar parenting stage. 10 years ago, I don't think either of us used our health plan at all. Now, you got a family and you've got other circumstances that mean that you do. You use it more often. Mm-hmm. And it seems to me that employers are actually taking on a lot of expense that's, growing fast and has grown, at 10, 15% year over year for decades now. And their only way to sort of manage that is to start to turn it into something that's more defined as a specific budget. And it just seems like employer is going to have to make that shift. And as a result, it's got to be something that members, patients, individuals have more agency within. Yeah,
for sure. And, I mean, I feel bad because I'm definitely costing my insurance plan a lot with, I tore an ACL and then 6 months later, my wife tore hers. And then a year after that, I tore mine again. So it's like, oh my gosh, we have all this expenses coming out of us.
Yeah, that's what it's for though, right? That's when you want it, when you need it.
Yeah. So how can people, kind of learn more about what you guys are doing at Arrive Health and connect with you online to, if they're interested in continuing this conversation?
We are, LinkedIn is a good place to engage with us. We're pretty consistently putting things up there. ArriveHealth.com is the website. We've got a team at a conference in Vegas. There's a big, almost like the CES of healthcare is in Vegas this week. It's called the Health Conference, HLTH. We've got a team there. If you happen to be at that conference, come see us. Yeah, those are probably the best ways.
Awesome. And I'll link that up in the show notes too at geekleader.com. Kyle, thanks so much for coming on the show. Really appreciate it.
Yeah, glad to be here. Thanks, John.
Hope you enjoyed the show. Please go to geekleader.com to learn more about what this guest is up to. Click on their links and connect with them online. I would also greatly appreciate it if you could leave me a rating and review in Apple Podcasts or wherever you listen to the show. Make sure you've subscribed if you haven't already. And if you feel so inclined, you can leave me a tip by going to geekleader.com/tip.